Good afternoon to all the esteemed participants and distinguished guest scholars. I'm Suman Pant, a doctoral student at Coventry University and research associate at the Partnership for Sustainable Development Nepal. It is my immense pleasure to welcome you all to the second session of the South and Southeast Asia Climate and Health Responder course dedicated to the critical theme of degraded air quality. This course is organized by the Global Consortium of the Climate and Health Foundation at the Columbia University Irving Medical Center in collaboration with the esteemed regional partners, including the World Health Organization Southeast Asia region, the Center for Chronic Disease Center, India, University Malaya, Monash University, Ashoka University, University of Management and Technology Pakistan, Partnership for Sustainable Development, and others. Similar courses have been successfully held in Africa, the Caribbean, Europe, and Latin America, focusing on regional climate and health issues. These initiatives aim to enhance contextual learning and explore locally driven solutions to address the pressing health impacts of climate change. At the heart of these efforts lies a shared vision to equip the health professionals with the knowledge, tools, and leadership skills needed to place health at the center of climate change response strategies. As frontline responders, health professionals are uniquely positioned to advocate for policies, implement community-level interventions, and build the resilient health systems that safeguard vulnerable populations against the worsening impacts of the ongoing climate change. Our shared mission is to ensure the responses that are actionable, equity-focused, and sustainable for lasting outcomes. This comprehensive 11-session course held every Wednesday at the same time covers critical and regionally relevant topics for health professionals, including the health impacts of climate change, vector-borne and zoonotic diseases, extreme weather events and disasters, building resilient health systems, mental health challenges, and many more. This session aims to explore how climate change exacerbates the air pollution in our region, including the factors like ozone shifts, PM 2.5, toxic smokes, wildfires, and stubble burning. It also helps us understand how the temperature inversion effects leading to winter smoke. It helps us identify sources and health impacts of national and transboundary air pollution, discuss the mitigation strategies to reduce air pollution and protect public health, examine the effects of pollutants on climate-sensitive diseases, highlight the vulnerable population, and outline the role of health professionals in protecting these groups. This 90-minute session will feature expert lectures and case study presentations, followed by a Q&A session. Participants are encouraged to submit your questions through the Q&A platform. Session recordings, slide decks, and additional resources will be available on the course website. Attendance is automatically recorded during the live sessions and is counted only if you join using your personal Zoom link. Joining through a colleague's link or watching YouTube will not count towards your attendance. It is important because participants who attend at least 7 of the 11 live Zoom sessions and pass the final exam with a score of over 70% are eligible to receive a certificate of participation. There are the exam towards the end that consists of 25 multiple choice and true and false questions, and it must be completed in one sitting. Moving on, we are honored to have with us today a distinguished panel of experts who will share their insights on how degraded air quality is affecting public health in our region and what solutions are within our reach. It is our great privilege to introduce Professor Dr. Kurmi, who is a distinguished researcher with a solid foundation in public health, environmental health, and respiratory epidemiology. He earned his undergraduate degree from Tribhuvan University in Nepal and a PhD in public health from the University of Aberdeen in the UK. His postdoctoral training at the University of Birmingham's Institute of Occupational Medicine enhanced his expertise as a former senior scientist in respiratory epidemiology at the prestigious Clinical Trial Unit Service Unit and Epidemiological Studies Unit of Nuffield Department of Population Health at the University of Oxford. Dr. Kurmi contributed significantly to advancing the field. He has also served as an assistant professor in respiratory epidemiology at McMaster University in Hamilton, Canada. He is an associate professor of epidemiology and evidence-based healthcare research at Coventry University. Currently, he leads the cluster on public health and life course epidemiology. He was the chair of respiratory epidemiology group within the European Respiratory Society and a fellow of Royal Society of Public Health. His research focuses on respiratory epidemiology and environmental health epidemiology, and he is dedicated to educating the next generation by teaching observational research methods and problem-based learning to undergraduate and postgraduate students. Notably, he established a family cohort in 2 regions of Nepal to uncover critical health determinants related to children's lung health. Professor Budi Haryanto is a professor of environmental health at the Faculty of Public Health, Universitas, Indonesia, and serves as the director of Research Center for Climate Change. He has been a member of the board of directors of the Pacific Basin Consortium on Environment and Health since 2008, a committee member of the International Society for Environmental Epidemiology since 2020, a fellow of the Collegium Ramazini since 2020, and an honorary visiting professor at the Global Research Center, University of Canberra for the term 2024 and 2025. Recently, Professor Budi led research on health impacts of transportation-related air pollution, particularly asthma and pneumonia, in Indonesia, which contributed to a national policy brief for the Ministry of Planning and Development. He has also played an active role in global climate discussions, participating in UNFCCC IPCC events such as COP. Without further ado, I would like to welcome Professor Kurmi to deliver his presentation. Thank you. Over to you, Professor Kurmi.
Thank you, Dr. Suman. Thanks for the kind introduction. And hello, everyone. Today, I'm going to talk about the degraded air quality in South and Southeast Asia. So when we talk about the climate change, it's not many people think of about the heat, which is an important factor, but it's not only heat. It is also the air we breathe in, which is getting more deadlier and causing a lot of adverse health impacts. So if you can take one message from my whole presentation, I think this is the slide which I want you to remember. We all know about the COVID-19. The figure you see here in the left is from the WHO, where within 3.5 years, about 7 million people died across the world. And everyone were very worried, and it was right. Everyone were worried because their health were impacted, the movement was impacted, and it affected their quality of life. But when you look at the global air, the air pollution, this is a report from the State of the Global Air, which was published in 2024. And based on the data in 2021, they reported that 8.1 million died in 2021 just because of the air pollution. And around 58% were from the ambient sources, whereas 38% were coming from the household air pollution. And most of these death which is coming are coming from the low and middle income countries and South Asia, Southeast Asia, and African regions are contributing a lot on this one. If you look at the global risk factor, this air pollution is regarded as the second most important risk factor for death in 2021. And when you look at children less than 5 years old, almost 750,000 people die due to air pollution. And it is the second largest in the South Asia region as well. So when you talk about the major threat of climate change, we come across number of factors: air pollution, which is rising temperature, extreme weather events, spread of infectious disease, to name some of the few. Whereas air pollution comes as one of the important factor. Now, what we need to do is we can't take this air pollution in isolation. What we have to do is we need to have a joint plan where we can include air pollution combined with human health and act. Everyone should come together to act on this. According to the WHO in 2019, they reported the 10 top threats to global health, and air pollution and climate change were listed on the top. And these both are the same two sides of the same coin. When you talk about the climate change, there are number of climate change affects number of factors. You can see it induces the global warming, which also is directly associated with number of primary pollutants which are produced from the sources. For example, you can have soot, particulate matter, you can have volatile organic compounds, you can have sulfur dioxide, and also it affects the secondary pollutants such as ozone level as well. It also affects the health outcomes, the crop productions. I won't be talking on those, but mainly my talk will be related with the air pollution and associated health impacts in the today's presentation. So let's start what are the key air pollutants and their sources. So there are a number of natural sources as well as man-made, which is anthropogenic sources. Then in the natural sources, you can have the volcanic eruption impact, which might give to eruption of releases of a lot of acid gases like sulfur dioxide and cause number of short-term health impact as well. There are the wildfires. You might have noticed in different part of the world, it is also common in South and Southeast Asia as well. It contributes to harmful airborne pollutants such as particulate matter, number of greenhouse gases, which can contribute to long-term air quality issues and will impact on the health. There are like dust storms can also transport the fine particulate matter to long distances as well, and they can cause a number of health impacts as well. I've taken this picture from the field where I work in Nepal and India as well. So the top left you can see is a crop. Once the crop are harvested, they burn the field to get rid of the leftover the fat there. The second one again coming from Kathmandu, which is the forest fire as well. And if you see at the bottom here, this is many people, mostly in the rural areas of developing countries, whether it is South Asia or Africa, they use the solid fuel for cooking and heating purpose and are exposed to a very high amount of air pollutant as well. You can see there are a lot of small scale industries. For example, this one is coming from India, which is from a jaggery plant where we work very close to Delhi as well. And you can see the smokes coming from there. These all contribute to a lot of air pollution there. And the air pollution is not uniform throughout the season. We all know that. In different seasons, if you look at in the winter, you might get a lot of air pollution. Just before the rainy season, you will have experience a very high amount of air pollution coming there as well. So there is an influence of whether on air pollution level. For example, temperature. If you have an increase in temperature, you might have increase in the ozone layer in the troposphere, which is high temperature because they enhance the uh, maximize the ozone formation, which will worsen the air quality in many different parts, mostly in the urban areas. The wind might affect as well. So wind, um, um, if there is a low wind, it can trap the pollutants, and strong wind may help to disperse the air and the pollutant from one region to another. But it doesn't take away the air pollution. It disperses from one region to other. It might dilute the air quality. The rainfall as well, we can see during the just the monsoon season. Before the monsoon season, we if you have a high air pollution, they might decrease the air pollution. But these are short lived. It could be short lived as well. You might have 1 or 2 days of rain, and then following that you might get a increased layer of air pollution as well. So rainfall may act as a short term increase or long-term decrease of air pollution as well. The other source which we see from our region, South Asia and Southeast Asia, is the transportation and industries as well. The transportation, having the vehicles, coming from the vehicles, different type of airborne pollutants, whether it could be particulate matter, it could be NOx, it could be many other chemicals which we like volatile organic compounds and many other things as well. They might contribute to the greenhouse gases as well. They increase the temperature as well. So you have ammonia, you could have methane gas, you can have the waste burning. There are a lot of sources and different types of air pollution, air pollutant emitted from different sources, and transportation industry are the one of the major as well. We rely on agricultural practices, and the type of agricultural practice we do also have an effect on the air quality as well. The air pollutant might increase due to the methane, ammonia, particulate matter, use of pesticide, which is getting more frequent in many part of the South Asian region. Waste burning, the waste coming from the household, we burn in the open, that increases the air pollutant as well. Stubble burning, as you saw in the previous the small video clip as well. Stubble burning is a major source. You might have heard in different big cities like India, the Delhi, which get a very high amount of air pollutant, and that's mainly due to the stubble burning as well. We need to have a regulatory change. There is a lack of proper policy as well. And even if we have a policy, they are not implemented properly. So there is a challenge of implementation of the policy as well. We also need to have a sustainable practices, which could be implementing eco-friendly practices that can reduce the airborne pollutants from in the atmosphere. There are a number of ozone layers, ozone variation in stratosphere and troposphere as well. In the we know that the stratosphere ozone layer helps us to protect from the UV radiation, and because of the human activities like release of chlorofluorocarbons, it can lead to significant decrease in the depletion in the stratospheric ozone, which might have an adverse effect on the animal and plants as well. There is the troposphere ozone, which is a secondary pollutant. You can see during the summer season, you have an increased level of ozone, and this is the rising emission of NOx and volatile organic compounds mainly in the urban areas. They can increase the ozone levels as well, which will increase the climate change and also increase the temperature, which we see more frequent nowadays in different part of the South and Southeast Asia as well. And all these elevated ozone levels you might have seen short term, the health impacts, hospitalization, hospital admissions increase during the high ozone level as well, having particularly the respiratory disease, cardiovascular disease. We see the increase during this high ozone formation season. So I'm just trying to give you a little bit of the concentration and the trends of air quality just based on few countries of the South Asia. So here you see on the left, it is the average annual population weighted particulate matter, PM 2.5, which is from 5 different countries in South Asia. That is India, Nepal, Pakistan, Bangladesh, and Sri Lanka. And what you see is from the 1990 to 2020, which is almost 30 years, there was a for 20 years there was 10-15 years there was a stable PM 2.5, but now you see in the last 10-15 years there has been an increase in PM 2.5, particularly coming from the air, the ambient air quality. So that's the outdoor air pollution. But when you see on the right hand side, the figure on the right hand side, it is from the solid fuel, which is coming from the domestic use of burning of wood, biomass for cooking and other. And in all these countries, it is coming down, which is a very good sign. Yeah, but it is still not enough. Around these are the proportion of household using solid fuel. For example, in Bangladesh, over 70% of the uh, people still rely on solid fuel. In Nepal, it is almost 67%. In Sri Lanka and India has come recently, it has come down to almost less than 40%, but by 2020 it was around 60%. Pakistan around 50% of the population use. So still there is long way to go. We need to reduce the use of solid fuel for cooking and heating purpose, because the amount of air the very high exposure they get is quite big during the cooking period. This is the left figure you see is the average annual um, population weighted NOx, nitrogen dioxide, which is you can say there is an increase in the NOx in all these countries. And on the right hand side, the figure is for the average seasonal population weighted ozone levels, which is increasing in all these South Asian countries, and which is a worry as well. And it impacts the air pollution, the pollutant, the ozone level, which is a factor in the one of the major pollutant for the climate change. Now, looking at the health impacts, this is the DALYs, age standardized DALYs, that is disability adjusted life years per 100,000. Now you can see here, let me see if whether if you can see my cursor here, you can see in last 15 years, there has been an increase in dailies due to PM 2.5 level. And on the right, you see is the death in these countries. You see a steep increase in the death in all these 5 countries, whether it is Bangladesh, Nepal, Pakistan, Sri Lanka, and India. And you see for the India, because you have got this is a rate for 100,000, and you a lot of in urban areas and even in the big cities where you see a lot of very high level of air pollution. The figure here shows you the dailies. In the first figure is for the household air pollution, which is coming down. It's a very good thing. And then the death, which is coming in the right hand figures, and that's also it is coming down. But in certain countries it has stabilized. For example, Bangladesh and Nepal, for the last 10-15 years there hasn't been a continuous decline, which is again a worry, and we need to encourage the people to get rid of these solid fuel. But importantly also the policymakers and other need to support those individuals, because mostly the poor, those who are having low socioeconomic status, they are using the solid fuel and they can't afford to switch to other unless they get support from the government or other agencies, and that should be encouraged. I'm just showing you this. There have been a number of major episodes of severe air pollution. I just wanted to focus one of them, which is everyone probably knows the 1952 the London smog, which was due to domestic coal burning in 1952. In 1952, in the first week of December, you see here, because due to very high increase in sulfur dioxide, there were around 4,000 deaths recorded within a couple of weeks in London, and this was uh, because of the high increase of dioxide. But this data will reanalyze in 2012, and they reported that it was not only 4,000 deaths, there were around 12,000 excess deaths due to the increase in the mainly sulfur dioxide. And because of this severe air pollution in London, there was the Clean Air Act introduced in 1956. And the reason why I'm showing this is how a good policy can impact the changes in the air quality. Before, in 1940s, 1950s, you see the sulfur dioxide was the main contributor of the air pollutant source, where there very few transport there, mainly people used to walk or bicycle. And because of the London smog, there was the Clean Air Act in 1956, and because of that, there was a very good implementation of the policy. And you can see the types of different pollutant. After the introduction of Clean Air Act 1956, there was carbon monoxide, lead, and ozone were the major pollutant there. More cars, transportation vehicles, less people started walking. And in 1998, there was an introduction of banning the lead in the fuel. We use for the running the cars and vehicles. And following that, then you had a different sort of pollutant, which is NOx and particulate matter. There are more, sorry, there were more vehicles there. And if you look in UK in 60 years, from 1950 to 2012, there were 10 times increase of vehicles on the road. The walking, which was encouraged, has decreased significantly. And the UK government brought rules. They were focusing on the reduction of the particulate matter. In 2000, there were around 14,000 of cars which were run using the diesel. But because the policy which encouraged the diesel use, by 2014, in 10 years, 15 years, the from 14% it increased to 50%. Now you can see the policy, how the policy changed. Now they have realized it's not only the particulate matter, it's also the NOx which is contributing to severe health impacts as well. Now they have in UK government has a product policy. By 2030 they want to get rid of the diesel vehicles. So you can see how good or bad policy they can encourage the increase of air pollutant, or if there is a good policy they can decrease the air pollutant level as well. Now, we saw this slide previously. There has been a global trend in the use of solid fuel as well. Now you see different regions here. There have been continuously decline from the 1980s. This is all showing until 2010, but believe me, this is the same continuing till now as well, and which is a good thing. But when you look at the population, using solid fuel, around 2.8 billion people in 1980s, they were using solid fuel. And if you look here, still around 2.83 billion people use the solid fuel. So the number of people using solid fuel for cooking hasn't come down. It has declined because the population has increased, but still around 40% of the population, they use solid fuel. And in some part of like Africa, it is increasing as well. This is a quite old data which we measured in Nepal, and it is still the same. Here you see on the top left graph, which is PM 2.5 in microgram from the household using solid fuel and carbon monoxide. So there you see, this is for a typical household in a typical day, and within 24-hour period. The peak you see here are during the cooking period. There is a very high exposure level of particulate matter and other airborne pollutant during the cooking period. And these people, those who cooked, mostly the women cook, children stays with the in the kitchen. If they are very young, they stay with the mother, and they are all exposed to very airborne pollutants. And if you look at the indoor air quality in certain part of the Nepal, where mostly in the rural areas where they use the solid fuel, it's over 500. The average 24-hour is 500 microgram per meter cube. In the urban areas is even 100, which is many times almost 20, the 15-20 times more than what is the WHO guidelines as well. And these are mainly coming in the urban areas. It is mainly coming from the transport there. When you look at the socioeconomic status of individuals, this is a data from the UK. I didn't find from the developing countries, so I use this one just to make a point. Those who are poor, and this looks as PM 2.5 concentration and deprivation in London. What it shows, the indoor, you can see on the right graph here, those who are very poor, they are more exposed to airborne pollutants. They are higher exposure to airborne pollutants, meaning that those who can't afford good treatment, they are the ones who are facing the higher burden of airborne pollutant. So I think we need to act on this one. The poor who can't change to cleaner fuels, the poor who can't live away from these transport, big roads and other, they are the one who are having a higher exposure to airborne pollutants. And this figure shows you the loss of life expectancy from various risk factors. And this was published in 2019 from the Health Effects Institute, which is the data they took is from the Global Burden of Disease Studies 2017. And what it shows in 2019, children born in 2019 will their lifespan will be decreased by 20 months, 1 year just because of ambient air pollution, and 9 months because of the household air pollution. And this is not uniform. This is taking the global average. But when you look at country-wise, for example, where you have got higher air pollution, if you decrease that air pollution, they are the one who will gain most from this loss of life expectancy. For example, in Bangladesh, if the air pollution was to the WHO, the guidelines, they will gain around 7 years of life. India 5 years, Nepal 4 years, Pakistan almost 4 years. So you can say these regions have a very higher exposure. They are the one who are impacted by the adverse health impacts of airborne pollutants. And if we reduce, they are the one who will gain the most. Now coming to the health impacts, there are number of studies which has given, there isn't any, I was looking at the disease which I can exclude, but you're looking at this figure, there are number of diseases here, from the neurodegenerative disease, cardiorespiratory disease, the premature birth, low birth weight, cardiovascular, COPD, cancers, you name any. And there are number of studies which has given some sort of evidence to show the association between the air pollution and the health impacts. But most of the studies are focused coming from the high income countries, and they are mainly with the cardiorespiratory health and some the birth weight, low birth weight as well. So this is the, let's start with the children. This is the my son who was in Nepal. I mean, he used to live here, and he was there for a year in Nepal and in Kathmandu. And after a few months, he he never had an asthma. He got the asthma. He was diagnosed with asthma, and which was causing due to the airborne high air pollution in Kathmandu. He used to be hospitalized for many days every month, and so you can see the impact of these airborne pollutant on the children. And the reason why the children are more vulnerable to airborne pollutants, because the different organs are still developing. For example, the lung is growing still, the other organs are developing. They have a small airway as well, which can be affected by inflammation. Their metabolic systems are not fully developed. They do not have a very developed host defense mechanism at that time period. And these children, the younger the children are, the respiratory rate is much higher, means they are exposed to, they can inhale much more air than the adult population. So these are impacted. These are the most vulnerable groups. I don't know whether you have seen, this is a picture of Ella, who was living in London, and she died in 2013. She had a very rare type of asthma which got worsened because of the toxic pollutants, airborne pollutants. And unfortunately, she died in 2030. And the coroner reported that this was the first case where you found that the death was caused by airborne pollutants. This is the first case anywhere in the world showing that the air pollutants caused death. It was not only the airborne pollutant, there were other, the genetic as well, but airborne pollutant was one of the major factors here. So giving the first evidence showing that the airborne can cause death in different groups, particularly the vulnerable population like Ella, who had a rare type of asthma. This figure you see is from Professor Arvind Kumar from India, who is a chest surgeon in Medanta Hospital. The top left, you see the healthy pink lung, and the one top right, you see the diseased black lung, which is maybe smoking different because of the disease. But I just want you to concentrate on the bottom left, the figure here. This is a teenager's lung, which the picture was taken by Professor Arvind Kumar in India during the surgery. And this is a teenager's lung, non-smokers, and the patches you see here, these are coming mainly from the air pollutants. You can see black patches, carbon particles coming there, deposited in the lung of these teenagers. And it's not only the teenagers, the elderly, many other people get exposed to very high airborne pollutants, and it causes a number of adverse health impacts. I just wanted to show you, it's not the children and the adults. Before you are born, the airborne pollutants, if you have got a high exposure to airborne pollutant, not only in the developing countries, but even in the developed countries. This is a study published in the Lancet Planetary Health in 2020 from a group of scientists from Belgium and UK. They did a study in pregnant women in Belgium. What they took the samples, maternal and perinatal and fetal samples, in 60 randomly selected mother neonate pairs. What they found, those women who were pregnant, they measured the black carbon levels outside where they were living, and they found this had this correlate with the black carbon levels found in the different samples. They also did a study in Scotland. The same study published in the same paper they published from the Scottish, the Aberdeenshire. What they reported here was they recruited the women's or girls who were pregnant, but they didn't want the child. They aborted the healthy child, and 36 they measured the airborne pollutants. Sorry, they measured the black carbon levels in the place where they were living. The age of the fetus when they aborted was 7 to 20 weeks old, and they measured the black carbon level in different organs, in the lung, liver, and brain. What they found was the black carbon level measured outside their homes and the black carbon level in found in the those different organs of the aborted child, where they were correlated, suggesting that it not only affect the children when you are born, it already start affecting very early when you are still unborn. The fetus is developing very early stage as well. So this is, you can see, it affects the unborn child, the children at different age, the adults, elderly, everyone. So this is another from the Professor Jonathan Grigg from London. They measured they took out the sputum. They had a sputum sample and measured the airway macrophage from the sputum. Just keeping the story short, they measured the carbon content in that sputum. So the carbon level, you can see here the black dot here. These are the carbon here. So when they analyzed, they modeled the data, and what they found, the amount of carbon content was directly associated with lung health. So the more carbon particles were in the found in the sputum, the worse lung health they had. And they compared for UK and Ethiopia as well. So what they found, the Ethiopia were exposed to much higher airborne pollutants. They had worse lung function and the lung health, both in the adults as well as in the children. There is another very famous study. I think many people would know, the ESCAPE study, which is the European study of cohort of air pollution effect. This was conducted in 14 different populations in 12 EU countries, taking around over 74,000 women, those who were pregnant. And what they found is every 5 microgram increase in PM2.5 concentration was associated with 18% increase in low birth weight. Similarly, every 10 microgram increase in PM10 was associated with 16 microgram increase in lower birth weight. Similarly, 10 microgram of per meter cube increase in NO2 was associated with 9% increase in risk of low birth weight. Now you can see here in the top two, the PM2.5, the smaller the particles, the deep it can penetrate in your lung, different bloodstream, and the higher the effects they will have. We also carried out a study in Nepal. This was carried out in a tertiary hospital where we measured took the sample from 4,000 mother babies pair in a hospital in southwestern Nepal, and out of those 4,000, 1,000 over 1,200 mothers were using biomass while they were pregnant. They were cooking in the cooking using biomass, and when we analyze the data, around 42% of those women who has used biomass or solid fuel for cooking, we were doing the cooking using biomass or solid fuel, they had 42% has small for gestational age, means that the baby were small to their the gestational age, and the risk was almost 5-fold higher compared to if you are using the LPG. When we compared the LPG and the household air pollution, the risk was 5 times. So you have got low birth weight, small for gestational age. You can see the evidence from those reasons as well. Again, the ESCAPE study also, they published the data from the birth cohort, Germany, Sweden, Netherlands, and UK, around 6 to 8 years old. And what they found was they measured the annual exposure of NOx and PM2.5, 10, and coarse particle as well. They found every 20 microgram increase in NOx was associated with 0.86% increase in FEV1. FEV1 is force expiratory volume in the first second. It is a measure of how good your lung is. there. So, and again, every 5 microgram increase in PM 2.5 was 1.77% in decrease in FeV1 level there. You might say this is a very small number, but if you look at the number of, if you look at combine the whole population, it is a very, very significant and big number as well. The other famous study, which I think most of you know, is the 12 South Californian communities. They had they recruited at 3 different time period. They measured the hourly NOx, ozone, PM 2.5, and 2 weekly PM 2.5 and acid vapors. They also found the same things. So they found that the children who were exposed to higher concentration of these airborne particulates had a lower lung function, that is lower lung capacity there. But the good thing is, once they realized the air pollution was so bad, there was a change in policy. The air pollution was decreased, and they measured the lung function again, the lung health again after a few years. And these children who had a poor lung function or lower lung function compared to the normal reference values, they quickly recovered, and they got the full lung. I mean, the lung were healthy. They were as good as the those having the uh, not exposed to higher airborne pollutants. So this shows that if you have a good policy, you can improve the health. The other, again coming from the South California study, they also measured the proximity of child living in the freeway, which is a like motorway, or the which I mean in big roads where you have got a lot of traffic you can take. Measured in 500 meters, living in 1 kilometer and 1.5 kilometer as a reference value. What they found, those children were living 500 meter compared to those living in 1.5, they had lower lung quality. Their lung function was significantly affected. Means if you are living close to congested traffic with lot of air pollution, you are likely to have poor lung health as well. Again, there are a number of, I don't want to go into detail, but there's the climate change. Also, there is a increased frequency. We see the extreme weather such as wildfire, floods, heat waves, and these also increase the risk of respiratory infections. It could be different direct or indirect mechanisms. Most of the mechanisms, I must admit, we do not know the full how they affect, but there have been some suggestion which I'll be coming to later in the slides as well. But what we know that these higher the effects of climate change and air pollution, it increases the COVID-19 incidence as well. It increases the morbidity, mortality from the COVID. It also affects many other health impacts which we have been talking recently. And as I said, we do not completely understand the full mechanisms, but there have been a suggestion, most of them coming from like the inflammatory, the oxidative stress. These are some of the mechanism how airborne pollutants they affect the different organs, whether it is brain, kidney, placenta, fetus, cancer, mainly coming. These most of them are coming from the cardiorespiratory health. We don't have studies coming from many other different health outcomes. So just quickly looking in the young adults, this is one of the study we did in again in Nepal. This was the first study looking at the young adults, looking at those exposed to household air pollution compared to those using clean fuel. What we found was those young adults 16 to 25-year-old, by the time, and for your information, the lung grows and it attains maturity by mid 20s in the boys, by 20s in the girls, and after almost next 10 years 15 years they remain constant, and after that it start declining. But by 25 years, these children, the young adults from 16 to 25-year-old who were exposed to airborne pollutant, they already has a decreased lung function, or you can say they are a poor lung. And if you have a poor lung, you are likely to get a lot of the health impacts, adverse health impacts like cardiorespiratory disease, whether it is cardiovascular disease, whether it is COPD, asthma, much younger. Now we see when you look at the data in different part of the world, it used to be the COPD used to be called the disease of the old elderly people. But now you see in mid-20s, mid-30s, there are many peoples. I've analyzed data from the China, from the South Asia. We see a lot of people, they are getting COPD and other disease quite young. So this is another study where I was involved in. This is in 10 different provinces of China as well. This is the first longitudinal study with over 500,000 sample size. And this was published by one of my PhD students when I was working at Oxford, K. Chan. And what he found was that using solid fuel increases risks of COPD in China by 12%, respiratory related death by 45%, acute lower respiratory infection by 18%, acute upper respiratory infection by 56%. Now here on the right, you see the forest plot from the different type of, for different disease, major respiratory disease, which is chronic lower respiratory disease, COPD, lower respiratory infections, and where we took the always clean as the reference values. Those who use always coal and wood and mix always wood, you could see here there is something like those who used wood has the most adverse impact. And we also try to look at the number of years they have been using this. So we divided into 3 different categories: using less than 20 years, 20 to 39 years, and more than 49 years using solid fuel. What we found a dose response relationship means the longer you use these fuels, the longer, the more higher adverse effect you will have. We saw this one in these children. Like smoking, it is never too late to give up smoking. If you are smoking, you need to give up smoking. Same is with the pollution as well. If you are exposed to higher, it is never too late. Even if you have been exposed to 20, 25 years, it's always to give up, try to adopt cleaner technologies to for the improvement of health improvement there. We also look into the kitchen, which has ventilation, which didn't have proper ventilation. What we found was having a ventilation reduced the risk, but it didn't take away completely. So means to have a much better impact, ventilation is important, but giving away the polluted fuel is very important as well. This another was published in the JAMA from the same study as well for cardiovascular and all-cause mortality. It's the same figure. When we use for different, it again shows the dose response. The number of higher higher the number of years you have been exposed to this, the cardiovascular risk is and all-cause mortality increases as well. It's not only cardiorespiratory. We looked into the major chronic lung disease and compared with smoking as well. So from the same study, we published this one, and that if you are using solid fuel, you had a risk of almost 26% of higher risk of having major chronic liver disease. If you are just smoking, you are current smoker, you have 28% of higher risk of getting major chronic liver disease. But if you smoke as well and exposed to solid fuel, the risk increases. So there is a synergistic effect of there. And if you switch to clean fuel, you can see there is the risk almost came down as well. Those who switched to cleaner fuel, the risk was much lower. It wasn't even statistically significant. This is another study I was involved from the pure study, which is in 29 different countries. And we looked into the data from 11 countries, Bangladesh, Brazil, Chile, China, Colombia, India, Pakistan, Philippines, South Africa, Tanzania, and Zimbabwe as well. And this was followed up is a prospective data we followed for 9.5 years, the data presented here. Again, the same story. So it's not one study. I'm trying to give different studies just to reinforce that it's not one study somewhere is showing the risk. This study again shows that the risk of all-cause mortality increases by 12%, the risk of fatal and non-fatal cardiovascular disease increased by 8%. For the respiratory, fatal and non-fatal respiratory disease by 14%, and non-fatal cardiorespiratory outcome by 12%. We looked again in the cataract and biomass in Nepal as well. Those, again, this is a cross-sectional. It doesn't show you causality. It's just showing you the association. But it is important because the risk is too high. You can see here the exposure to biomass. This was taken in Nepalese women only. And what we found was there was twofold increase in cataract in women who were using biomass fuel. Um, and those who only used biomass fuel for their whole life, there was threefold increase in, and we mostly saw the nuclear cataract. There were like the symptoms, the ocular symptoms like redness, burning sensation, complaint of pain in the eye, these all were significantly associated. We also found the severe impaired vision, which was associated with airborne pollutants there. Now, again, looking at all these studies, most of them are coming from the uh, uh, developing countries, and they are very limited cardiorespiratory health impacts. I'm looking at the time, so and we need to have more evidence from the developing countries on the health and long term, mainly the long term. We do have a lot of short term, we need to look long term as well. So what do we need to do? It's not a rocket science. We all know, everyone, I think every one of you know there. We need to have, everyone has to come together to as a whole community to work, from individual to the industries to the policy makers. Everyone has to come together and make their commitment in reducing this air pollution. It is important for having a regular monitoring air pollution and communication. We need to have eco-friendly solutions as well and research-driven solutions. I think that's important as well. As I said, we need to have an integrated approach of managing the air quality and public health as well. I think community is the major. We need to engage the community to bring in the community, because they are one who can make a real life difference in the field. The clean technologies is available. We need to, whether it's solar, whether it's other different, we need to come in, make best use of these. Reduction of green gases, again using different technology which is there. Greenhouse gas emission we need to reduce to mitigate the climate change and improve quality, and this will also affect the economic growth as well. So I think we need to have the policy, which I already talked about. The proper policy implementation is very weak in this part of the world. We need to have a stringent regulation that can be implemented, and we need to have a sustainable practice as well. So in summary, air pollution is bad, whether it is ambient, whether it's coming from forest fire, it is coming from different sources. You can see a dose response relationship between number of diseases as well. And I think we all need to come together as a community. We can do it. But we need to, like we all came for the COVID, we had a lot of vaccine developed in record time. We all need to come together. We need to make sure it is urgent and communicate to the policymakers, the community, the researchers, and everyone. If we can come together, we can make a difference. Thank you very much.
Thank you. Thank you, Dr. Kurmi, for your insightful and comprehensive lecture. Your presentation effectively highlighted the major sources of air pollution and the critical pathways contextual to Southeast Asia region. And the contextual evidence that you said from our region regarding the health impacts, very heterogeneous number of health impacts, and the extraordinary number of deaths was both alarming and thought-provoking. Breathing is the very essence of life, and if that's polluted, it impacts, and no one is left behind. It affects at the very beginning of life till death. And additionally, the discussion of the major historic episodes of severe pollution from the other parts of the world was truly eye-opening, offering very valuable lessons on the profound health impacts and underscoring the vital role of the policy interventions in addressing these issues. our participants have that very vital role now to really communicate, to integrate the knowledge and skills of climate change into their practices to save and improve the productive life years of our citizens in our region. So without further delay, thanking Dr. Om, we'll come back again with the question and answers. There are really burning questions from our participants. They have very actively participated in our session. So without further delay, it's my honor again to invite Professor Budi for the upcoming case presentation. Over to you, Professor Budi. Thank you.
Okay, thank you, moderator. Distinguished ladies and gentlemen, distinguished participants, it is a very honor for me to share a case study in Jakarta that the problem has already been mentioned by the previous speaker. And we can see here, let's say, just repeating the situation that in global, WHO has named air pollution as the world's largest environmental health threat. So, of course, we should take into account this problem. And yes, unfortunately, the air pollution and its impact, it seems that neglected by everyone because we inhaled, we are breathing in every 3 seconds or 20 times a minute. Yeah? So, because this is actually our nature behavior, nature life. So, the pollutant in the air we inhale is seen that already neglected, yeah, by us. And of course, this is a very danger for us. So let's see the case study in Indonesia. Okay, before that, I'd like to show you that in 2019, our within data showing that in the top 5 of death caused by diseases is related to air pollution. Yeah, among top 5 are related to the air pollution. Then we can see here that just emphasizing that the air pollution is affected to almost all of our important, very, very important organ, yeah, in our body. So it seems that we are not have ability to avoid it. And based on our current research, we found that the diseases related air pollution is at least 12 diseases, yeah, with the International Classification of Diseases 10 revision. You can see here. We can see acute upper respiratory infection, influenza, and pneumonia, other acute lower respiratory infection, and even lung disease due to external agent, and then also ischemic heart disease, pulmonary heart disease. So, so many diseases actually that can be used for detecting whether we already been exposed in certain level of air pollution or not. Okay, and this is our study also in 2013 to 2017 in Jakarta by putting the data from 1990 to 2013. We put it in the modeling from data developed by IIASA, International Institute for Applied Science, in Austria, that being utilized by almost all of the world. So we found here that until 2030 in Jakarta, almost all of the pollutants are increasing significantly. And the color stands for the source of the pollutant. For example, we can see here heavy duty vehicle diesel, light duty vehicle gasoline, light duty vehicle diesel, and also motorcycles. And we may see here VOC emission, CO emission, PM10, PM2.5, and OH are increasing until 2030. Of course, this is the fact that we should take into account. And this is another finding from our research. We can see here by doing what do you call it, primary collecting primary data, we found that among respondent for more than 4,000 respondent in Tangerang and almost 3,000 in Makassar, we found that asthma affected to already suffer in the 1.3% population, while the abnormal lung function, we found about 25% and Makassar 24%. It's been that in Tangerang, one among five people are having abnormal lung function. And we can see here among housewives in industrial area, living industrial area, yeah, we found that about 38.5% mother having the lung function impairment. So 21% for general population, and while 39% lung function impairment among housewives that living surrounding the industry area. And we can see here among those who are almost daily life on the road, these are public transportation driver. We found that their lung function impairment about 56%. So we can see that among three studies, for general population is about 21%, for housewife living surrounding area of industry 38%, while those in daily life on the road having lung function impairment about 56%. It's showing us that the exposure from transportation is actually the dominate to the impact to our health. And we also found that there is an association between ambient particulate air pollution and cognitive function in Indonesia children living in forest fire prone provinces. We have a very frequent of occurring very frequent occasion of forest fire. So this is very important finding for us to to taking into account of as well. And this is showing that transportation exposure is very important for us. We can see here this is using a personal exposure measurement as already been presented by the previous speaker as well. In the left side, yeah, here is a PM 2.5 for 24 hours measurement, and the respondent are equipped with the measurement, the equipment. Yeah, you can see here during on the road about 1.5 to 2 hours on the road. The point to PM 2.5 inhaled very high. Yeah. Well, at the office it's quite low, but when back home about 2 hours again, inhaled the respondent inhaled a very high concentration of PM 2.5 as well as at home. And for carbon monoxide, you can see here is the exposure on the road is very high. Yeah, it is during 1.5 to 2 hours. The CO concentration inhaled by the respondent is very high, about 9 times than the standards, WHO standard. Yeah, and when they are at the office, very low of concentration inhaled, and when on the road again, on the way back home, they inhaled again very high carbon monoxide concentration, and when at home, very small carbon monoxide inhaled by the respondent. It shows again that the exposure from the transportation is very important because it seems that it's dominated the source of the pollution in Jakarta. And not only in the ambient outdoor pollution we measure, but we also do the research on the at home, yeah, inside of the home. So children refractory allergies is also found as the most risk for the diseases related to air pollution. And here we would like to show you the disease related to air pollution and cause of illness in Jakarta. The someone in the box of in the room of question and answer asking about the consequences in the cost for payment for the illness. Yeah, you can see. Okay, I'd like to tell you that this is actually we collect the data from medical record. Yeah, medical record from the hospitals in Jakarta in 2010. And we found that about among all of the diseases, almost 60% diseases are related to air pollution. And when we measure the cost of payment, this is a tangible cost actually. We found that about they by Indonesian rupiah it's about 38 and half 38.5 trillion Indonesian rupiah, or is almost equal with 2 or 3 billion US dollar. Yeah, only for Jakarta. Yeah, the maximum of payment for illness caused by air pollution is about $3 billion in 2010. Okay, this also a new finding by Vital Strategies, yeah, in 2022, with the measure to the infant death, stunting, adverse birth outcome, mortality, and hospitalization. They found that the cost for treatment is about $3 million. Okay, and we can see in Indonesia, 47% of air pollution are contributed by transportation activities. Yeah, so the government focus on this transportation in order to control the air pollution. Then the transportation actually the most priority to be to be to be tackled. Yeah, and you can see here the most currently government develop a scenario to uh, to provide a better quality of fuel. Yeah, for example, here the scenario in 2024, 10% of fuel or diesel fuel are implemented. The diesel fuel implemented with the concentration of 50 ppm of sulfur content. And then in 2025, increased to 34%. And then in 2026 and 2027, 64%. And the scenario in 2028 to 2030 will be 100% of fuel, diesel, and also fuel, fossil fuel is implemented to reduce all of the not good fuel that up to now has already been utilized by about 85% of population, 85% of vehicles in Indonesia. Okay, by this scenario, this is actually the characteristic of the quality of the fuel. For example, here under Euro 2, this is actually being used by about 85% of population vehicle in Indonesia. Yeah, under the quality of the fuel is still under the standard of Euro 2. And if we use Euro 2 standard, that is sulfur content will be 500. If we use Euro 3 standard, it's about 350 of sulfur content in the diesel and 150 in the gasoline. For Euro 4, it is 40 50 ppm of sulfur content, and then for Euro 5, 25, for Euro 6, 10 ppm sulfur content. This show that the lower sulfur content in the fuel or diesel it will be beneficial for the health impact. And this is also our newest finding that without significant intervention, air pollution in Jakarta estimated increasing 40% in 2030, with the baseline from 2033. 2033. Okay, we can see here that scenario into 2030, if we do nothing, we are not doing improve the quality of fuel and diesel, the PM 2.5 and PM10 will be increased 28%, while for sulfur will be increased about 29%, NOx 28%, hydrocarbon is about 42%, and carbon monoxide about 43%. While when we implementing the Euro 4 standard, the PM 2.5 will decrease about 96%, sulfur 98% decreasing, NOx 82%. This showing that the very significant decreasing when the fuel quality is being better. Okay, and this is the projection of emission load of PM 2.5 scenario Euro for diesel in Indonesia that already shared to you previously, that in 2004 when we implement 10%, the PM 2.5 will be like this, a bit decrease. But when in 2025 increasing to 24%, it is quite good decreasing. When the total scenario implementing Euro 4 until 26 is about 63%. So the PM 2.5 will be decreased, and when implemented in 100% in 2028 to 2030, then it's will be showing the decreasing, significant decreasing compared to business as usual. And when we are talking about the beneficial for the health, for example, here we choose the pneumonia cases. This is in 2024, 10% decreasing, 10% of implementation of Euro 4 standard. This is business as usual, the case of pneumonia. And it is when the intervention or implementation of Euro 4 standard utilized in Indonesia, then we can see that in 2030, there will be an 86% reduction of pneumonia cases in Jakarta. Well, for the cost of treatment that claimed by the national insurance in Indonesia for pneumonia, it will be decreasing about, this is about 15 million, $15 million US, decreasing of one of disease that affected by the implementation of Euro 4 standard. And when we see about COPD, chronic obstructive pulmonary disease, the reduction is also about 84%, and the decreasing of the claim for national health insurance is also very significant. And one more example you can see here, that for ischemic heart disease, there will be about 70% reduction in 2030, and the decreasing of national health insurance is also decreasing significantly. It's about 15, more than 15,
Yeah.
about 16 or
Sorry,
17
sorry for the
million US
interruption.
dollar.
We are out of time. We'd be very grateful if you could conclude in a minute.
Okay,
Thank you.
let me go faster. Okay, and by the study, we found that every increasing of 15 microgram per cubic meter of PM2.5 associated with the increasing of 20% cases of pneumonia. And every increasing of 15 microgram per cubic meter PM2.5 is also associated with increasing of 27% COPD cases, and increasing of 15 microgram per cubic meter PM2.5 is also associated with the increasing of 37% cases of ischemic heart disease. And if we can see here that for non-communicable disease in Indonesia, affected to 60% of deaths. That's because of the disease of cardiovascular, diabetes mellitus, cancer, COPD. And okay, this is the last two slides. How we control the pollutant with the source of transportation. Of course, we have to reduce vehicle on the road, improve fuel quality, and implement clean energy, adequate engine technology. This must be comply with the better quality of fuel or diesel, and manage land transportation, avoiding the traffic jam, and increasing the number of air quality monitoring system. And for human protection to air pollution, of course, it is very suggested that the people should read the daily forecast through applications, to see what air pollution forecast look like, because this is very important to choose to make a decision to go outside or still at home, and close the doors and window when the air quality index is over than 151, and recirculate the air in your car while you drive, just a few minutes, and wear a mask that filters outwards air particles. Take a shower after spending a lot of time outside. Travel to work a bit earlier, so you aren't exposed to as much exhaust, and switch to a healthy diet, so you aren't as vulnerable. And as the conclusion, air pollution is major cause of diseases, which mostly non-communicable disease, and putting more Jakarta population in severe risk of serious health effects. Air pollutants are highly existed and estimated sharply increase in the future. Air pollution-related disease is preventable and manageable. Willingness, commitment, focus, and serious actions of all stakeholders. Thank you.
Thank you, Professor Budi, for your very enlightening contents and bringing us the case presentation from Indonesia, and helping us understand the health and economic implications, and what can be done from the transportation sector to improve the air quality. So thank you all, our audience. We want to make this announcement that we have collected all of your questions, and we request our panelists to answer them. But for now, we will be taking only a question each for our panelists. But we make sure that all of the queries from our audiences will be answered from our guest lecturers. So our question to Professor Kurmi So I'll merge like two kind of questions that are very burning. So the first is like the effect of AQI to acute respiratory conditions, ARI, is cumulative exposure to cluster days of poor AQI, or is there any lag effects for individuals to develop the ARIs? And what can be, I'm integrating other question, what can be done at the very individual level and at the government level to implement measures aimed at reducing the air pollution? Thank you. Be very succinct. Thank you.
Yeah, thank you. So just to be sorry for taking more time for the, I think there are different factors which might affect. With regards to lag, we have looked into different disease, and there are different factors which account for whether you how healthy you are, whether you are a vulnerable population, whether you have got any comorbidity. So overall, we looked at published in the Lancet group looking at the lag period. So there most of them for most of the disease we see 1 to 3 days lag was we saw there different level of effects and for short-term exposures. I can share that articles in the probably later in the if you want to look into that. The other was I think how can you protect? I think Professor Budi already in last second last slide he did mention. I think I will probably encourage you to focus some of them there. There are individual measures trying to reduce the exposure as much as possible by different means, whether it's mask or any other staying indoors or trying to have some proper ventilations and all those things. So I think that's as a government level, yes, there is a need to cut down the pollutions there in cities, different places. So I think I'll stop there because of the time.
Thank you. So the question goes to Professor Budi. With climate change influencing the air quality, how do you see the trends in PM exposure and associated health risks evolving over the next decade?
Okay. Actually, the explanation has already been mentioned by Prof. Kurmi, yeah, previously. But I'd like to share that to share opinion that okay, because of okay, let's start with the greenhouse gases actually came from the emission of the activity of the combustion, yeah, everything combustion from uh, vehicle emission, from the use of let's say coal, yeah, and also from the uh, agriculture, yeah, for methane. And that is actually in the same time, air pollution is also the pollutant is also emitted, yeah, in the same time. So not only the greenhouse gases, yeah. Then of course it is the first source of the air pollution in the inhaled by people. And then secondly, actually, the climate change affected to the uh, to the air quality because of when in the dry season, so the burning or a fire and other dust is also goes to everywhere. Then this is also affected to the human health.
Thank you. So thank you to all of our participants for your active participation and very thoughtful questions. Apologies for exceeding the time limits. It's really truly encouraging to see such an extraordinary engagement on this important topic. So we have shared a link to get your feedbacks for the today's session, and we also request our participants to join the course WhatsApp group for the updates and information from the course planning team. So with this, I'd like to thank our guest lecturers, for their invaluable insights, and thank you all participants. We look forward to welcoming you all in the next session. Thank you all. Have a good afternoon, have a good evening. Thank you all.
Thank you.